And in today's session, we will discuss about the pathological or abnormal changes which are associated with the small animal abdominal sonography. I hope I am audible to all. There is no issues. Should I start?
Yes, ma'am.
Hello. Okay, fine. I'll start. So when talking about, uh, yes, please. Okay, fine. So while performing sonography, we have by now known what are the normal appearance, how we need to perform sonography, do we need to follow a specific order or sequence, and then we know what is a normal appearance, what is the normal shape, ego texture, parenchyma's appearance, is it homogeneous, heterogeneous, like that we have discussed in the previous two lectures. When talking of abnormalities, we need to know about the variations or deviations from the normal. So we should think of it in the following manner, like is there any increase or decrease in the any changes in the shape, change in the size, whether there is some hypertrophy or the size is reduced, whether there are changes in the contour of the organ, whether it is a homogeneous straight normal capsule or there are some deviations, any changes with respect to position, number, and ecogenicity and ecotexture of the organ. Like for ecogenicity, this is again just as a review, the comparison of ecogenicity, where fluid being the most anechoic, and when we talk of prostate or peritonitis, that will be the very hyperechoic, will appear very white. And again, ecotexture for that, where we told it is to be fine, homogeneous, or heterogeneous. These were the appearance in terms of ecotexture. Then the uniform appearance can be uniform, or there can be mottled appearance, there can be some focal or multifocal lesions, or heterogeneous parenchyma can be there. So all these things we will talk about. First organ which we will discuss will be the liver and gallbladder. So we know we have to perform examination at the region of post-xiphoid, and then when we talk, what we will see for its size. Generally, we cannot say, like this was a question which was asked in the group. How can we say what is the size of the liver? So there is no definitive criteria which will say that the liver has to be this much centimeter in length or breadth or width. There is no defined size of the liver, but yes, definitely it is to be within the rib cage. So when we are performing sonography, we can say what is the transducer position, and with respect to that, whether it is crossing beyond the xiphoid or beyond the costal arch, then we can say yes, definitely there is some hepatomegaly. Also with respect to the margins, suppose liver on the, when we are examining on the left side, then liver should not cross the margins of the stomach. So if it is crossing beyond stomach, then we can say there is a definite hepatomegaly. Talking of the margins or borders, then liver should have very sharp margins. Okay, it should have razor sharp margins, but if there is some irregularity like rounding or smoothing, then we will say this is abnormality. Ecogenicity, we know how do we need to compare the ecogenicity. It will be hypoechoic as compared to the spleen. So if in case it is getting hyperechoic, then we will say yes, there is some hepatitis associated changes which are going on. And then the appearance of veins, we know that the portal veins, the walls will be very bright, they are hyper reflective because of the connective tissue present within them, whereas the hepatic veins, they have the very clear anechoic fluid going inside them, and the walls, they are not very bright as compared to the portal veins. So these changes should be kept in mind. And then we can see if there are any abnormalities, then whether they are focal or multifocal, or it is present in the entire parenchyma of the liver. So suppose the size of a lesion is less than 3 centimeter, then we will say it to be a nodule. And if the size of that lesion extend beyond 3 centimeter, then we can say there is a large mass. um, and these nodules or mass, they can be anechoic, hypo, hyper, or heteroechoic. and there can be some target nodules which are associated with metastasis. Suppose there is a tumor which get metastasized into different organs, liver being one among them. Then in such cases we can see target nodules. I'll show you the images. And there can be dystrophic mineralization, maybe especially associated with hyperadenocorticism, in which there will be calcification in different body organs, or maybe some associated with some other changes. So we will see most of these things pictorially. Okay, this is the table. If you will see, when you see it in deeply, then it is showing, yeah, that these things, these conditions, they will have anechoic appearance, then hypo, hyper, and mixed decogenicity. But it is not very absolute. There are much overlapping. Something like, say, necrosis. Necrosis can appear anechoic also. It can appear hypoechoic also, and it can be mixed decogenicity. So means all these are overlapping. It is showing that it can be anechoic to hypo or to mixed decogenicity. So we cannot be very sure by seeing an organ, and we do not give a definitive diagnosis for any lesion. In ultrasound, we have to describe the appearance of the lesion which we are seeing instead of giving a straightforward diagnosis. We have to give differentials and suggestive diagnosis. Similarly, for generalized changes, these are against different diagnostic considerations. And for size, if it is increased or decreased, then what can be the various regions. Like suppose if there is fibrosis, we talked about the size. If there is fibrosis, chronic fibrotic changes, the liver is cirrhotic, then obviously the size of the liver, it will reduce, it will go within the rib cage. And some other changes like hepatopathy or congestion, they can be associated with the increase in the liver size. So as I told, this is a hypoechoic nodule within the liver. We can say, yes, this is a liver. We will say nodule. Why? Because when the size is measured, if the size is less than 3 centimeter, we will say these lesions to be nodule. And we will compare its echogenicity. It is hypoechoic as compared to the surrounding liver parenchyma. So it is a hypoechoic nodule. And later only, maybe by taking some biopsy, then only we can identify these lesions. These type of lesions can be seen during the regeneration process also, nodular regeneration. Whenever the liver undergoes some toxic insult and it is regenerating, at that time also we can see the appearance of such type of nodules. Then here again we can see another nodule, and some degree of congestion can be seen. So this is a hyperechoic nodule. We can just say hyperechoic nodule. We cannot say what does it signify. For getting the proper diagnosis, we have to take a biopsy sample, maybe a fine needle biopsy, ultrasound guided biopsy we can take, and based on that, the cellular pathology, we can determine what that particular lesion is. Again, here we can see these are the target nodules. I told it is having some hyperechoic center followed by a hypoechoic rim. So these are the appearance of target nodules, and these are generally seen in case of metastasis. We can see metastasis within the liver parenchyma. Or this is a primary. Actually, based on biopsy, it was diagnosed to be a histiocytic sarcoma. Again, after the nodules, we can see these are the masses. Here is a somewhat hyperechoic mass which is occupying the liver parenchyma as compared to the normal. So, and this we can see there are multiple cavitatory lesions of variable sizes, and these are generally anechoic to hypoechoic, multiple coalescing lesions. So it is a very typical moth-eaten type appearance of the liver parenchyma, and it is a hepatocellular carcinoma. Here we can see some mineralization within the liver, and this mineralization, it is causing acoustic shadows beneath it. Again, here what we can see, generally I told that the liver parenchyma, it should appear granular, but here what we can see that it is somewhat smooth. Its appearance is looking like smooth, and the portal veins, the characteristic portal veins which were having hyper echoic, hyper reflective boundaries, they cannot be seen. And this is a image from a dog which was having diabetes mellitus. So we can see there is somewhat increased echogenicity, and the portal vein markings are reduced. Now here in this liver, whenever we are seeing, we must ensure that the diaphragm lung interface is within the view, so that we can see the entire up to the most dorsal aspect of the liver. And here we can see that the liver is a bit hyper. It is just opposite to the previous image which was seen. That was hyperechoic. This image is hypoechoic. In that we could find very homogeneous fine parenchyma, but here we can see so many of portal vessels. These are all portal vessels marking. And upon biopsy, this case was diagnosed as a case of lymphoma. So, like for size, two things I told, like if the size is extending beyond the xiphoid or beyond the coastal arc, then we can say yes, the liver is enlarged. And here we can see this is the stomach. This is the stomach, and the liver margins, they are extending beyond they are extending up to the caudal aspect of the stomach. Then in this case, we can say the liver is enlarged. Also, we can see the margins, they are not very smooth. There we can see somewhat rounding of margins. These margins of liver are not smooth. Now this is starry sky appearance, and it is most characteristically seen in cases of acute hepatitis where there is any. However, it can be seen with other conditions also, and at times in normal conditions. But generally, most commonly, this starry sky appearance, wherein these portal vessels, they are very bright, it can be seen in cases of acute hepatitis. Now this is a case of a liver abscess. Actually, we cannot see the far boundary of this liver abscess. Why so? Because this abscess, it was associated with some microorganism which were producing gas, and because of the gas, the near boundary of the abscess, it is showing the reverberation artifacts, because of which the distal boundary cannot be seen. So it is an example of a hepatic abscess. Only after taking the sample, we can say yes, it was an abscess. And the type of lesion which we can see is emphysema. The abscess can be clear also. It can be anechoic. It can have somewhat cellularity. We will see in the coming slides. Okay. So these are example of hepatic fibrosis. I told you in hepatic fibrosis, the size of liver, it will reduce, and the margins, they will not be very smooth. We can see the convolution of margins. The margins are convoluted, and it is shrunken. And most, see also here also, this is again an example of hepatic fibrosis. These fibrotic changes are generally associated with ascites. So we can see these clear black anechoic free fluid within the abdominal cavity. Now these are the images which are showing hepatic congestion. In this, we can say this is the portal vein. It is draining into the caudal vena cava, and we can see the portal vein. It is highly congested. Here also, this portal vein is markedly dilated. Here also, we can see branching of the portal vein into right and left, and these are again severely dilated. By applying the color Doppler, we can assess the flow also. So these are example of hepatic congestion, and these hepatic congestion are generally noticed along with the right-sided heart failure. Okay, so in that case, the venous there is no proper blood supply, and then in that cases there is pooling of blood within these hepatic vessels. So hepatic congestion is generally associated with right-sided heart failure. Next, after liver, we will talk of gallbladder. See, in this is a distended gallbladder. Again, here we can see distended gallbladder. Its shape can be different, varying depending upon the level of distension. So here we can see there is presence of sludge, ecogenic sludge, which is gravity dependent. It is settling towards the gravity. And this sludge can be incidental finding, or it can be pathological. So suppose there is a geriatric dog. So in those, we can see sludge as a normal finding, but seeing it in a very young dog, then it can be associated with some pathology. Next, this is an example of cholecystitis. In cholecystitis, this is the gallbladder wall. This is the gallbladder wall. This wall is thickened and it appears hyperechoic. Generally, the gallbladder wall should not be seen, and it will be less than 1 millimeter in the thickness. So here we can see it is hyperechoic. The thickness of the wall has increased. There is some mucus here also. here and the sludge is very hyperechoic. Also, it is associated with some effusion, some cranial effusion. These crescent shaped effusions can be seen. So, whenever we are seeing this thickening of the gallbladder wall along with the presence of echogenic sludge, we can say it is cholecystitis. And if the inflammatory changes are seen along with the liver, then it can be cholecystohepatitis. Again, here you see this is the liver parenchyma and this is the gallbladder. Here, apart from being thickened, the gallbladder apart from being thickened, you can you see these black colored area, this anechoic area in the gallbladder. So it indicates edema. The gallbladder wall is edematous also. It is an image of the cat, and in cats, generally in dogs, we cannot see the cystic duct. I told you in the previous lecture also. But here, these you can see, these are the cystic duct. These ducts are again thickened. These are again thickened. This is thickened. So here, this is a cholecystitis with gallbladder wall edema and the thickened cystic duct seen in diagnosed in cat. And here we can see this is colilith. These are coliliths. Okay, so there can be stone formation within the gallbladder, and these stones, they will cast distal acoustic shadow. There will be shadow beneath these. So these are coliliths. The wall, again, you can see this is very hyperechoic generally, and it appears thickened also, hyperechoic. The sludge is not very anechoic, it is having some echogenicity. Sludge is having some echogenicity. So these are coliliths. And these are gallbladder mucocele. These mucocele, they have a very characteristic kiwi fruit appearance. You can see these multiple striations like this, like this. So this is a typical image of mucocele. And here you can see this is again very character. See, the wall is from here to here, and you can see this anechoic content in the gallbladder wall. This anechoic content in the gallbladder wall. Here also, this is the gallbladder wall thickness. Definitely it is more than 1 mm. Definitely it is more than 1 mm, and it is having black anechoic contents. So this is gallbladder wall edema associated with the mucocele. And mucocele, it is actually abnormal accumulation of mucus and bile salts within the gallbladder, and these can be emergency. Next organ to see is spleen. So for spleen, when we have to see the size is increased. Splenomegaly, it is again like for the liver, size of the spleen is also very subjective. And in this, we can say either if the tail of the spleen is impinging upon a flaccid, voided urinary bladder, definitely then we can say that it is splenomegaly. The other criteria to judge that spleen is enlarged, if the width of the spleen is more as compared to the renal width, renal cortical width, again we will say it to be a splenomegaly, or at the level of splenic hilus, then there also we can measure the width. So these are some of the examples where we can see the spleen is enlarged. Here also, see, you can see this is very fine parenchyma of the spleen, which is associated with several circular hyperechoic nodules in the parenchyma. You can see multiple hyperechoic nodules, and this is nodular hyperplasia. Here also, this is the splenic parenchyma. In this, the size of nodule is somewhat larger, but again, this is a nodule. So it can be a solitary nodule, or there can be multiple nodules. These nodules can be hyperechoic or they can be hypoechoic. They can be seen at time of maybe regeneration, nodular regeneration of that organ, or maybe at the time if there is some extramedullary hematopoiesis is going on, then also these type of nodules, not this, but these type of nodules can be seen. Okay, now this one you can see is a splenic infarct, although the condition is not very commonly seen. Here you can see this is the splenic hilus, wherein the splenic vein is entering to the spleen, and this is not having very anechoic. This should be generally anechoic, where we can see there is some echogenicity and the blood supply is occluded to the spleen. So this is a splenic infarct. Here again, a splenic abscess which is having some gas producing organism. This picture is almost similar to that which I showed you into the liver abscess. Here also there are some gas producing organism which, because of which the gas is rising up against the gravity, and the near wall of that abscess is associated with the reverberation artifact. They are casting these dirty shadows. And here you can see, apart from this abscess, otherwise also the parenchyma of the spleen is not homogeneous. Here are some multiple ill-defined hypoechoic nodules. Now this is an example of hemangiosarcoma. You can see multiple nodules, some of which are hypoechoic, some are hyperechoic, which are present within the splenic parenchyma. You cannot simply say this by seeing the appearance. You need to take biopsy, and then only any condition can be definitely diagnosed. But otherwise you can just simply tell that the what is the appearance, what is the normal appearance, what are the changes in the echo texture, what are the changes in the echogenicity. Like that you have to describe your lesions while preparing the ultrasound report. Generally these hemangiosarcoma, they can bleed also, so may be associated with some free fluid. Like here you can see some free fluid that you can see, and this fluid will generally be echogenic because there will be blood, it will be blood filled. Next, this is a picture from lymphoma. The nodules in lymphoma, they can be like multiple small cavitatory lesions which at times are coalescing with each other, or it can be in form of a large nodule, maybe at a splenic head or at the region of splenic tail. So these are pictures from splenic lymphoma. So all in one, I'm just want to share that I'm showing you different appearance, the sonographic appearance of lesions may be associated with neoplasia or other cysts or abscess. So you cannot just give a confirmatory diagnosis. You just have to say that the appearance of lesion is like this. Now see, these are multiple nodules, large size to small size nodules, which are hypoechoic in appearance, and the case was diagnosed to be a histiocytic sarcoma. And here we can see a large hypoechoic nodule which was confirmed to be a mast cell tumor. Here this appearance is said to be honeycomb appearance associated with lymphoma. This I have already shown you in this previous picture also. So this honeycomb appearance is associated with lymphomas. And this is an image of splenic torsion, a condition very rarely seen, but can be associated with GDV, gastric dilatation volvulus. And in this, you will see these multiple parallel speckles within the splenic parenchyma. You can see these parallel speckles, or you can say lacy appearance, lace-like pattern. This is the spleen with its lacy appearance. It is very characteristic of splenic torsion. Next, coming to the kidneys, like we have to scan it in all the three planes, longitudinal, transverse, and the frontal plane. And the indications for performing the kidney examination, suppose if there is any palpable mass in one or both side of the kidney, there are some voiding abnormalities if there is hematuria, pyuria, or proteinuria. If we suspect there is acute or chronic renal failure, in case of uroliths, some congenital condition, polyuria, polydipsia. And with these, what we can say, the changes, the renal function, when it is altered, the sonographic appearance, the sonographic changes may be seen prior to the biochemical changes seen. However, it is not always true. So whenever we have to see for acute or chronic renal failure, we have to take a mix. We have to take the biochemical, the KFT levels, and we have to judge based upon the sonographic appearance, and then we have to decide and we have to treat, and we may need to follow up the case and serially repeat all these things. So various pathologies which can be seen. This is a kidney, if you can appreciate. The previous kidney which you have seen were having very nice corticomedullary differentiation. Here you can see that is reduced and it is having a cyst. Although when we have to say cyst, why we can say, because the contents are very clear, they are very anechoic, and the boundary is very well demarcated. However, it may be an abscess also. So, like on sonography, we can get a presumptive idea that it is a renal cyst, but it can be abscess also. So for confirmation, we can correlate it with the leukocyte count. If there is a deep cavity abscess, then it is associated with high TLC, high neutrophil counts, and a cyst will not have such changes. Or we can take a biopsy to confirm. So, but this is a gross anechoic appearance with the clear wall, g- generally most predictively of cyst. Next, nephroliths. There can be small to larger stones. These small stones, they are very incidental and they can be commonly seen in geriatric dogs, and they are not a point of concern. Here we can see these, with these stones, they are hyperechoic. The near surface can be seen and they are associated with the distal acoustic shadow. But if we see these large stones, then they can be an emergency and may need to be surgically taken upon. Other changes, see, we can see pylectasia or hydronephrosis. Pylectasia means the pelvis is dilated. Generally the renal pelvis, it can be measured in transverse or in the frontal plane. Okay, I'll show you the images what is renal pelvis. So in these two planes we can measure the diameter width of the renal pelvis, and generally the pelvis width should be less than 1 mm. However, if a dog is undergoing diuresis, IV fluid administration, or some diuretics are being given, then because the urine output is increased, the pelvis can be up to 2 mm. Then it can be normal. But if it is crossing beyond 3 mm, then it is said to be, the renal pelvis is said to be enlarged. So pylectasia is the enlargement of the pelvis, and hydronephrosis, it generally occurs secondary to any obstruction. Suppose there is generally in the urethral obstruction, or if there is a obstruction in urethra, then there will be some back pressure changes, because of which the ureter will be dilated and the back pressure, pelvis, renal pelvis will be dilated. The entire medulla, it will increase in size and it will compress upon the renal cortex. In chronic stage, the appearance can be like a very thin walled fluid filled cavity we can see. So see, this is, suppose in transverse scan we will see cortex and medulla. Here we can see the renal crest, and this is the origin of the ureter. So the distance from the renal crest to the origin of ureter, this is the renal pelvic width. This is the renal pelvis, and this is the renal pelvic width. And going more than, if it was more than 3 mm, I told it is pylectasia, and if the width is up to the level of 13 mm, then we can definitely think that hydronephrosis is because of the changes associated due to obstruction. It is having very high positive predictive value for obstruction. So here you can see this is a kidney in the transverse plane, this is the renal pelvis, and this is the ectopic, this is a ureter which is dilated beyond its normal. So the ureter is dilated, this is pelvis, from the crest to this portion is enlarged. This is pylectasia also. There are hydronephrotic changes going on in which the medulla, area of medulla is being increased upon. Then there can be diffuse renal parenchymal disease. So in diffuse, there will be changes in size, echogenicity, and the corticomedullary differentiation. It can be used to differentiate acute from the chronic kidney diseases, and we can see some neoplasia as parenchymal disorders. Then ethylene glycol toxicity, or maybe hypercalcemic nephrosis, they are associated with medullary rim sign. All of these images we will see in the upcoming slides. So this is an example of medullary rim sign, in which at the junction of the cortex and medulla, we will see there is some hyper reflectivity. These appears hyperechogenic, and it occurs generally associated with hypercalcemic nephrosis. And it is not much prevalent in the Indian conditions, because most commonly it is associated with ethylene glycol toxicity, and it is generally not used in Indian scenarios. But in normal dogs also, which is not having any such problem, there also this medullary rim sign can be seen, and it is not a cause of much concern. Now see, this is an example of neoplasia in the kidney. So for neoplasia, can you just think of it to be a kidney? It is not having any detail. Like we cannot differentiate where is the cortex, where is the medulla, and where is the sinus, renal sinus. No such area can be appreciated upon. So generally neoplasia is associated with changes in the size, in the ecotexture, in the ecogenicity, and in the entire architectural details of the kidney. This is an example of neoplasia, and you can identify only when you know the exact anatomical location of that organ. And here again, this is also a neoplasia. The corticomedullary differentiation, if you can see, is very much reduced. The size of the kidney is lowered. Here also, this is a kidney. No gross appearance of a kidney. The all the changes, there will be changes in the size and shape. It is having subcapsular hemorrhage also. So these tumors, they can bleed upon, and this was having subcapsular hemorrhage also. Perinephric. Here you can see, if you can appreciate, then please see that when we know this by orientation, standard orientation, this is the cranial side of the kidney and this is the caudal side of the kidney. Seeing the cranial is very much distorted, you cannot understand the pathology. These arrows, these small arrowheads, okay, this is showing the neoplastic lesion in the kidney, in the cranial side of the kidney, whereas a normal caudal parenchymatous area can still be seen, in which we can differentiate the renal cortex and the renal medulla. This is an example of renal cell carcinoma. Again, if we see this, so in this, the cranial parenchyma is a little bit preserved, but upon the caudal aspect, we can see the entire appearance is disturbed in the caudal side. This is again an image of renal cell carcinoma. This is a picture of renal lymphoma. See the contour, the margins of the kidney, instead of being rounded, these margins, they are very irregular. It is having somewhat anechoic fluid under its capsule. Here you can see again, and this this crescent shape is the renal pelvis dilatation. So you can describe that the corticomedullary differentiation is reduced, the renal cortical echogenicity is increased, and also the medullary echogenicity is increased. The renal pelvis is dilated. There is accumulation of subcapsular anechoic fluid. This will be the pattern when you are preparing a report. You cannot say renal lymphoma. I have just mentioned them below because from the literature where I have taken these images, they have taken the biopsy and they have diagnosed the case, and then they said that this was having diagnosis of renal lymphoma. But you just have to describe the lesion as they appear to you while performing the sonographic exam. Here, this is medullary band, similar to like that we have seen with the ethylene glycol toxicity. This is the renal cortex, this is the medulla, and at the junction of the cortex and medulla, we can see these hyperechoic medullary bands, which may be normal or maybe pathological. So you have to correlate whenever you are seeing these changes. You must take at least blood samples so that you can correlate with the KFT values. Again, here you can see the cortex is a bit hyperechoic. Cortical echogenicity is increased, and we can appreciate a cyst. Why I'm saying a cyst? Because the contents, it appear very clear. It is a renal parenchymal renal cortical cyst. The contents are very anechoic, and the margins, the capsule is very much sharp, demarcated. Now here, uh, this is again an example of neoplasia. You can see the corticomedullary details, they are reduced. The margins, they are very irregular, and the cortical echogenicity is increased. These type of changes, which now I'm showing now from here, these are generally associated with chronic kidney diseases. Okay, so chronic kidney diseases in CKD, CM differentiation, it will reduce the margins, the size of kidney, it will start to gradually shrinken, and margins will become irregular. there will be increased cortical echogenicity because from the nephron, the portion which are lying within the cortex, they get affected, because of which these increased cortical echogenicity, they are generally associated with glomerulonephritis or tubulonephritis. Here, see, this is the renal pelvis which is dilated beyond 1, or we can say 2. So whenever it is beyond 3 mm, we will say it to be pylectasia. It can also be seen as a change of CKD. Here, see, there is no much corticomedullary differentiation. We cannot see, the margins are not regular, the renal pelvis is dilated, and somewhat you can see these areas, these triangular shaped areas, these are appearance of renal infarcts. The blood supply is reduced and generally it is an infarct. Here also in this CKD, see this, the cortical thickness is reduced, it is hyperechoic. It is hyperechoic. There is some echogenic deposition within the medulla area. This is the area of mineralization. Here also some mineralization can be seen. The cortex thickness is decreased and the corticomedullary differentiation is reduced. Again, mineralization, the signs which are similar to medullary rim sign. Here you can see this is a renal cyst. This is the transverse view of the kidney. CM details, they are all lost. This is the renal pelvis which is dilated. This can be traced here. This is the ureter. Ureter again is dilated. It should be narrower than 1 mm. It is dilated here. And this is a clear content. This echogenicity which you can see is probably because of the side lobe artifact. Here, this is a perinephric cyst along outside of the kidney. Anechoic can be seen, and the size is reduced. The kidney appear globosed. Corticomedullary differentiation is reduced. So all these are related with the chronic kidney disease. Example of renal abscess in which some cellularity is there, which is locating toward the gravity dependent area. A recent abscess. Why abscess? Because definitely only upon taking biopsy they could analyze it to be, diagnose it to be an abscess. Here, this is again another image of renal infarct. It is a triangular shaped hyperechoic lesion due to the blockage of blood supply. The renal artery vein, then they will go into the arcuate vessels. So the blood supply, when it get reduced, there will be production of infarct. The margin here we can see they are irregular. Coming next to the urinary bladder. So the indications, whenever we suspect there is UTIs which are associated with abnormality in voiding, or we have taken some abnormal urine analysis finding, if there is a history of recent trauma and we may suspect that there might be ruptured bladder, or there may be some masses, we may suspect for neoplasm, we can, for diagnosing ectopic ureter, or for performing cystocentesis, and for taking biopsy, we may have to perform the sonographic examination of bladder, wherein we will see for the degree of distension, appearance of the wall, its thickness, any mass lesions, presence of clots or hemorrhage, or any foreign body. And generally, this urinary bladder, it is very easy to visualize things within the bladder when it is moderately distended, and it also provides a very good echo window to analyze other organs also in its vicinity. So see, these are the normal bladder images. It is in longitudinal section and it is in the transverse at the area of trigone. So it is ureteral papilla. I guess I have shown these images previously also. And these are the artifacts associated with the bladder, which can be seen normally. This is a volume average artifact. And this is acoustic shadowing, which is seen distal to the structures beyond the urinary bladder, because there is very less attenuation of the ultrasound signals through the bladder. So here you can see there is presence of some free fluid within the abdominal cavity, and this bladder is distended, and there is break in continuity of this bladder wall. So guys, any response? What do you think this condition can be? Anyone, please?
Euroabdomen.
Euroabdomen. Okay. Anything else?
Bladder rupture.
Bladder rupture, yeah, very right. Okay, anyone maybe at a first instance can believe this to be a ruptured bladder because we cannot see the continuity. But here we need to understand the importance of artifacts. It is an example of edge artifact. So suppose any ultrasound beam which is coming from here, and when it is striking this surface of the bladder, suppose the signal was coming like this, and when it strike this surface of the bladder, the sound signals, they were very parallel to the border, to this border, because of which no signal was produced from this edge, from this border. Okay, so it may give us an appearance that the bladder is ruptured. However, actually it is not. It is a very intact bladder, and this free fluid, it may be because of any other condition. It may be ascites associated due to changes in the liver, or changes in the kidneys, or any other organ. Okay, it is it is not associated with the bladder rupture. So if in case of trauma, I told, like, if there is any trauma and we want to confirm whether there's a rupture, what we can do, we can actually catheterize the bladder. And upon catheterization, whenever we are infusing the saline into the bladder, it should get distended. But because now it is ruptured, the bladder will not get distended, and the fluid, it will go now into the peritoneal cavity. And this movement of the fluid we can see, because along with fluid there will be some gases, and which will be hyper reflective, so we can see some of that movement. So this is not an example of rupture. For confirmed rupture, we can catheterize the animal and we can see the effect of distension. Now what we should assess, we should assess for the thickness of the bladder. And thickness generally we can measure at the this far wall, or we can say the dorsal wall of the urinary bladder, because at times these echos are better resolved in comparison to the near echos. So we can measure the thickness of the bladder, and the thickness will vary depending upon the level of distension. If it is very less distended, the thickness can be somewhere 2.4, 2.5, like that. And if it is very much distended, it can be up to 1.4 mm or 1.2 mm thick. When it is very much distended, then the bladder wall will get stretched out and it will become thin. So in any case, the thickness of the bladder should not exceed beyond 2.5 mm. And any thickening in the wall, as we can see here, the wall is thickened. Here we can see here the wall is thickened, then we can expect the case to be cystitis. Okay, and then in cystitis, apart from this bladder wall thickening, we can see the presence of turbid urine. The urine can be turbid. Here we can see the wall, near wall is echogenic. Now it is associated with emphysema, emphysematous cystitis. Then we can see there are some floating particulate matter. So these also either we can see. Now see, these are the images of emphysematous cystitis, in which the ventral wall of the bladder will be patchy, hyperechoic, casting the reverberations, shadows, the dirty shadows into the bladder. Here we get these shadows, they are just obstructing. So it is severe emphysematous cystitis. It is not allowing us to visualize the bladder, which an organ which is very, very nicely seen if it is normal. Here also we can see the emphysematous cystitis. Now next, there can be polypoid cystitis. So these polypoids, they are a pedunculated growth arising from the bladder wall. And to confirm whether these are growth or these are blood clots, we have to do some adjustments. Suppose maybe, because like if it is a clot, then it may be attached. In cases of chronic cystitis, it may get adhered to the bladder wall and may not show some movement. So what we can do, either we can put some normal saline, and if it is a clot, it will get dislodged. And if it very severely attached, what we can do, we can change the position, we can make the animal to go on some walk, and we can later on visualize. If it is a polyp, the position of it will remain fixed, the position will not change. But if it is some other clot like material, then it will break and it may swirl upon, and the position of it may change. So this is how we can differentially distinguish. And also we can apply Doppler to see any blood supply into these organs. So based on this, we can confirm it to be a polypoid cystitis. Now see, this again is a hyperechoic it looks like a hyperechoic mass. and it is now very much close to the wall. So how we can say whether this is just a clot or this is a tumorous growth? So if it will be a tumor, there will be vascularity. Yes, this was also one of the question in the chat, in the WhatsApp group which we are having, how to know the pathology associated with tumors. So generally tumors, they will have its major blood supply, it will be vascularized. The vascularization can be less, it can be more. You can just simply correlate with any surgeries you are performing. Some of the surgeries, they're very easily done, it is just having its one major, suppose taking mammary tumor only, one major blood supply, we just simply ligate and we can easily remove. And at time it gets so much of angiogenesis, there are multiple supplies and we have to ligate each and every vessel. So vascularization level differs accordingly. And here, if it is a clot, there will be no vascularization upon applying the Doppler. And if we are making the animal move, or we are administrating, infiltrating some saline, then again this clot, it can break upon it, it can swirl within the abdominal, it will move, it will change its position. So this is a way to differentially distinguish the condition. Now here you can see this is a urinary bladder, the contents of which are very turbid. These are not anechoic, and we can see this wall, the distal wall, it is very echogenic. It is casting some shadows. So these are some sediments which are getting settled toward the gravity side. And when we agitate the urinary bladder, suppose we are keeping the transducer on the ventral aspect and we just shake the transducer to produce some these movement within the bladder, these contents, they may just lift up, they may lift up and we can see the movement associated with them. So because of the presence of acoustic shadow, we can see these are sediments. However, at times if they are very small, then they may not even give the shadows also. Now these are transitional cell carcinoma, they can be seen at different wall layers. See here we can seeing at the dorsal here we can seeing at the neck of the bladder. This is the craniodorsal aspect, this is the entire dorsum of the dorsal wall of the bladder, and it is the at the cranioventral region. So the transitional cell carcinoma are one of the most commonly seen bladder neoplasm, and these can again be assessed based upon the level of vascularity and by taking the biopsy sample for confirmation. So here you can see this is a mass which we cannot say whether it is a clot, is it some tumor which is attached to the wall. So for confirming, what we can do, we can just simply switch the color Doppler on, and because now it is a tumorous mass, we can see the vascularization within this mass. Next, these are cystic calculi. These are multiple small cystic calculi. This is single large cystic calculi. These are again multiple large cystic calculi, all of which are casting acoustic shadows. So this is a way we can diagnose urinary bladder stones. Now this is ureterocele. Ureterocele means it is a focal dilatation of the ureters. Okay, so we all know that the ureter, they enter at the dorsal aspect of the bladder. So this is the dorsal aspect of the bladder, and here we can see generally ureters will be very thin. We cannot see them to be this much distended. This is having thickened wall. So this is an example of ureterocele. Here also this is an example of ureterocele. And these may be associated with ectopic ureter also. If they are not opening at this position and maybe at some other, then they can be ectopic. This is a dilated ureter, which should generally not be seen. And like any other structure which can be at this area is like aorta or caudal vena cava. How we can differentiate in aorta or caudal vena cava? When we apply color Doppler, there will be blood flow with it. And if there is no color Doppler facility available, then we can check for the pulsatile nature of the aorta. Next organ is prostate. So prostate, we all know it is located at the neck of the urinary bladder. And the changes, it is a bilobed structure, round, and generally it should be less than 5. Actually, the size of prostate, it varies with the age, the size of the dog, and based on that there is a formula. So the size of it will vary. Based on that formula, we can say if the size is enlarged or reduced. So it is not fixed. We cannot say the size of the prostate is fixed. It is based upon the body weight, then the size of the animal, and then status of neutering. If it is a castrated animal, the prostate will be small. If it is not, the size of prostate will be large. And for age, the prostate size, it will increase up to a certain age, after which the prostate will start to get atrophied. So this is an example of prostatitis. Generally, prostate should be very hyperechoic. It is more hyperechoic as compared to the spleen, and it is having a uniform appearance. But here we can see some heterogeneous appearance. It should be homogeneous, but here we can see some hyperechoic, then hypoechoic, hyperechoic. So it is an example of prostatitis. Now these are benign prostatic hyperplasia. In BPH, the ecotexture of the prostate will remain maintained. It is very homogeneous. It is hyperechoic, very hyperechoic structure, homogeneous ecotexture. Size and lobation are not disturbed. Lobations are not disturbed, but the size of it is enlarged with respect to what it should actually have had. So this is a case of benign prostatic hyperplasia. Here also the size is enlarged. This is a BPH. Here we can see some cavitatory lesions, which are prostatic cyst. Again, this is BPH with prostatic cyst. Here you can see prostatic cyst. These are prostatic cysts. This is transverse view. So we can get to know whether it is in the right lobe or in the left lobe. This is the right lobe, this is the left lobe. So definitely it is having cystic lesion in both the lobes. Next, after prostatitis and BPH and prostatic cyst, these cysts can be abscess. Okay, so every time the same rule will apply. One thing, just to get first hand image, cyst will be having clear anechoic content with a sharp margin, whereas in abscess there will be a little bit more of echogenicity, because abscess is more viscous compared to the exudate of the cyst. However, confirmation can only be achieved by getting a biopsy done. Now, this is a neoplasia. In prostatic neoplasia, the size of the prostate will be enlarged. The ecotexture will be disturbed. It is having multiple different hypo and hyperechoic appearance. There is random calcification at different places. There may be some large ill-defined nodules within the parenchyma, and bicolor Doppler we can see blood supply also. So this is an example of prostatic neoplasia. Coming next to uterus. So actually, whenever we are scanning uterus, this we can see in transverse section. This is urinary bladder. Below this we can see colon, and somewhere in between the urinary bladder and colon we can see the uterus. So this is a section of cross section of the uterus, generally not seen in a nulliparous or a bitch which is in anestrus. Now this is longitudinal section of the uterus. So, but anytime when it is associated with pathologies, then we can see certain changes. Like this is an example of pyometra, in which the size of the uterine horns is very much enlarged, and it is filled with anechoic to hypoechoic contents. There are presence of pseudoseptations. This is pseudoseptations within the lumen, and these are formed because an enlarged uterus will find its own shape. It will curl and it will be scanned in different planes. So these pseudoseptations can be seen. These are pus within the uterus, and these horns, they are just turning around to accommodate the space for themselves. Here also we can see hypoechoic content within the uterine lumen. So these are example of pyometra. If it is a closed cervix pyometra, definitely the size of uterine lumen, it will be large. But if it starts draining, suppose there was a corpus, there is a luteal cyst, and when the cyst is gone, the hormonal influence will be gone, the pyometra, it will start to get discharged, then the size will be a little bit less as compared to the closed cervix pyometra. But definitely then also it will easily be recognized, because definitely the size of uterus will be enlarged. Now these are example of cystic endometrial hyperplasia. Generally it precedes the development of pyometra. So suppose if we are scanning a dog, and in this time of scan we are not seeing any pyometra, but we can see these cystic lesions. See, this is the endometrium, this is the endometrium layer, and we can see here multiple hypoechoic to anechoic structures. So these are the cysts within the endometrium. So there are very high chances that in the next cycle the witch may develop pyometra. So And here, this is a cystic endometrial hyperplasia pyometra complex. The endometrium, its thickness is varying. It is having maybe some larger cyst, some smaller cyst. So all these are cystic endometrial hyperplasia changes. Next, stump pyometra. If a uterine stump is left and there is some ovaries are also left, then maybe there is some infection. At that time, there is accumulation within the stump starts. So at that time also, we can identify the stump below the bladder at its normal location, because the size of it will be enlarged, and this can be diagnosed as stump pyometra. Next, there can be some space occupying lesion within the uterus. So these are space occupying lesion within the uterus, and we can see these are highly vascularized. So these are any sort of neoplasia, the nature of which can be confirmed by taking biopsy. And this is the moth eaten appearance in the uterus. So these are neoplastic changes. This sonography now can be used for performing pregnancy diagnosis, and for that, different methods can be used. Like, earliest the pregnancy can be diagnosed around 16 to 19 days, and by assessing the gestational sac diameter, then there are various formulas in which you need to apply. If the machine is already having species specific packages for performing various exams, then there you just need to put, like, whenever you will be measuring this diameter, it will just tell the gestational age, the expected date of delivery by its own, if it is having package. But if there are no pre-installed packages into the machine, then we can just use some standard formula from standard text, and we can put these value into those formulas, and we can get the age. Now next, other ways we can measure the biparietal diameter. This diameter, we at the head region, biparietal diameter, we can measure to get the gestational age, or we can take the body diameter to get the gestational age, or we can use the crown rump length. So for different phases, different term period of the pregnancy, different formulas are used, and we will just put the values to get the gestational age of the fetus. Now, to know whether these fetus, if they are live or dead, what we can see the beating heart, or and to know the heart rate, because okay, we know the fetus is live, there is a heart rate, but whether the heart rate is normal or it is compromised, then we can measure heart rate by performing M mode sonography on that beating heart, or by using Doppler sonography. And next, it can be used to know, see, by x-ray we can know the exact number of fetus present within the abdomen, but we cannot be sure whether these fetus are, they are live or they are dead. So whenever performing sonography, we can know a dead fetus. A live fetus, it will be surrounded by presence of fluid, but in case of dead fetus, this fluid will be abolished, there will be no fluid, and maybe emphysema may also start, it may start getting macerated. So these are dead fetus. But in dead fetus also, we can assess the time period, we can take the history of mating, how many days back mating has happened, and then we can measure this biparietal diameter to know the stage of development. So we can say, like, the fetus was suppose 40 days old at this time, and now today it is suspected 42 or 43 days. So we can just assume that the fetus are now dead from 2 or 3 days, like that. Coming next to GIT. So see, generally the stomach will not retain anything within it, so it should be empty. If we see the stomach to be distended like this and it is retaining water, generally water will not stay, it will simply go. And if we are performing sonography and there is fluid within the stomach, then we can suspect either it has just now taken water, or there are some motility disorders, the peristalsis is reduced, the transit time is being increased, there is hyperistalsis. So this we can see, this is fluid filled distension of the stomach here. Now this is the normal appearance of the stomach, this is normal stomach appearance. But when, in case of gastritis, what will happen, the thickness of it will increase. Generally the stomach thickness should be less than 5 mm, but anytime if it is increasing beyond 5, then we will see it is, then we can say it is gastritis. In acute gastritis, only the wall thickness will increase, but in case of chronic gastritis, the layering of the stomach, it will be lost. We cannot see the layering appearance. Here also, see, layering will, here just wall thickness is increased, but layering is preserved. Here layering is not preserved. So that way we can suspect it to be gastritis. Now these are some gastric foreign bodies which are casting shadow. Foreign bodies, they can be very tricky because it depends upon the material which it is made up of. Suppose it may be a very hyper reflective metallic foreign body, then it can appear very bright with some distal shadows. Or there may be that balls, crazy balls can be used, so it just allow the sound wave to transmit through them, and we can see the entire boundary. Instead of seeing the shadows, we can see an entire cystic type of lesion. So these foreign bodies, they are very tricky. By appreciating them by ultrasound is very tricky because they do not have a very fixed appearance. The appearance will vary, but just taking one example, this is some maybe probably a foreign body which is casting shadow. Now this is an example of pyloric hypertrophy. See, this is the area of pylorus and this is the lumen. This is the one side, ventral side, and this is the dorsal side. On the dorsal side, there is severe thickening. This is the severe thickening, and whenever there is pyloric hypertrophy, what it will do, the gastric transit time, it will increase, because of which the dog may show chances of vomit. So it may be idiopathic hypertrophic pyloric gastropathy. Next, it what we can see, this is a stomach wall layer, and this wall layer here is very much thickened. The layered appearance is lost. So upon taking biopsy sample, the case was confirmed to be a gastric lymphoma. Otherwise, we cannot say any characteristic signs. If we see such type of pathology, then we will say it is a lymphoma. We can just say that the wall is thickened, the layering are lost, and it needs to be correlated by taking biopsy. Here what we can see, see, this is the portion of intestinal loop, these are portion of intestinal loop, and it is having these linear foreign bodies. These linear foreign bodies, it is casting acoustic, distal acoustic shadow, and you can see this appearance, this is how intestine is going around, it is not being very straight. Here also, these are the convolutions, these are convolutions of the intestine, which are generally, or plications we can see, these are associated with foreign bodies, because intestine, it will try to force to make the foreign body move, but it is not moving, because of which there will be different type of forward and reverse peristalsis, because of which we can see these plications within the intestine associated with linear foreign bodies. Now this very commonly seen in young pups is sign of intussusception. It is a target or bull-eye appearance seen in the cross section. It we can see multiple layering, target like, because multiple layering can be seen. It is having outer intussuscipiens and the inner intussusceptum. Also this hyperechoic area, it is associated with mesenteric fat. We have better picture of it, see here. This is a target appearance, multiple layered onion ring like layers. So it is a target appearance. This is the intussuscipiens, the outer layer. This is the intussusceptum. These are the mesenteric fats, and there may be blood supply also, which we can assess by applying the Doppler. And this is the longitudinal. In longitudinal, we will see multiple layers, because one, there is an outer encasing sheath in which the inner septum has been received upon. So multiple layer can be seen. This is a lymphangiectasia seen within the duodenum. So like I told, in the duodenum, these perpendicular hyperechoic lesions, these they can be seen, these are enlarged lacteal. So it is lymphangiectasia. Now these are carcinomas. Again here, the intestinal wall thickness was, it is not, see, by seeing the appearance, what we will say, it is not a normal appearance of intestine. In the cross section, the wall thickness is definitely increased. So when biopsy is taken, then only it can be confirmed. So next organ is like pancreas. Pancreas, it has its right lobe. its left lobe and body. And generally in pancreas, the most consistently seen area is the right side. The right side of the pancreas can be seen. Seeing the left side is very tricky because the left side of pancreas is associated with the stomach and the colon, the transverse colon, the stomach, all of which make us shadow and make the visualization of pancreas very difficult. So generally right side of pancreas is seen, and to identify that, what we have to do, we just have to locate the duodenum. We know that from the right side, duodenum, to identify duodenum is easy because duodenum is the thickest portion of the intestinal segments. It is the thickest portion of the bowel. The thickness is even maybe can be higher than the stomach thickness also. So when we identify the duodenum, then we have to go medially. We have to angulate our transducer medially to assess the right lobe of the pancreas, and this is the longitudinal way of identifying the right lobe of the pancreas. And the thickness of this, the width of the pancreas, should be somewhere in the, for dogs it should be in the range of 6 to 10 mm. And if the thickness, it goes beyond 1 centimeter, matlab it goes beyond 10 centimeter, then we can expect that some pancreatitis changes are going upon. See, it is a CT section. Here you can see this is the descending duodenum. Okay. And pancreas, it can be seen here, the right lobe, and the left lobe is seen somewhere here. This is the stomach. This is the lesser curvature of the stomach. It goes, the left lobe goes towards up to the lesser curvature of the stomach. So to identify what we have to do, we have to identify the duodenum and the pancreas. They will be located onto the medial side. First, we will identify duodenum. It is next to the right kidney, and then in between this we can see the pancreas, and it is associated with this pancreatoduodenal vein. This is a common vein supplying to the pancreas and to the duodenum. Assessing it can be tricky because the ecogenicity is somewhat similar to the surrounding structure. It is surrounded by fat, so it may be in front of us, but we may not just visualize that these are pancreas. And to assess the left side of the pancreas, what we need to identify, we need to identify this triangle, in which this is the spleen, this is the transverse colon, and this is the stomach. So see, in transverse, cranially it is stomach, caudally it is colon, transverse colon, and in between this we will be able to identify the pancreas. Now this, in the pancreas, what we can see, there are multiple nodules. This is the pancreatoduodenal vein. The pancreas, they have characteristic pancreatoduodenal vein, and it is having some nodular changes. So it is nodular hyperplasia in the pancreas. And generally, the changes associated in pancreas, what we will see, it will show associated changes within the duodenum and the colon, and it will give its hazy appearance. The appearance of pancreas will be a little bit hazy, and there will be some effusions surrounding it. So here we can see, when there is pancreatitis, the thickness was increased. When we are assessing the associated structure, then the thickness of duodenum is comparatively more thickened. And when we just assess the colon, the transverse colon, then this transverse colon, sorry, it also shows some form of seculations within it. So these are changes associated with the pancreatitis, and these are neoplasia within the pancreas. Multiple moth-eaten appearance can be seen, and upon biopsy it can be confirmed to be adenocarcinoma. Next, coming to the adrenals. Adrenals, how they can be identified? See, this is left kidney and this is the right kidney. These are renal arteries and vein going on, and these are the aorta and caudal vena cava. So these adrenals, they are located, we know that these are located cranial to the kidney, but not exactly cranially. They are somewhat craniomedial to the kidney. This is the appearance location of the adrenal. So what we have to do, we have to scan the kidney in a longitudinal manner. Once we scan the kidney, we have to fix the cranial pole of the kidney in the view. Then we have to go a little bit medial, towards the medial side, where we can see these renal vein and the aorta and caudal vena cava, they are coming upon. At that time, we can see this adrenal as a groundnut shaped structure. So here you can see this is the aorta when we fixed the kidney and then we moved medially and we just scanned the aorta. So it is seen cranial to this renal vein and medial to this aorta. Okay. So this is the appearance of adrenal gland. It is having its cranial pole and the caudal pole. Generally, the appearance of it is like the inner portion is hyperechoic, echogenic, and the outer rim is anechoic. Okay, when for assessing the pathologies, the caudal, the thickness of the adrenal, it should be less than 7 mm. And if it exceeds 7 or 7.5 mm, then we can expect pathologies of the adrenal. So here we can see this is the hyperechoic inner area surrounding by hypoechoic outside. The width, it is increased. It is more than 7 or 7.5 mm. Then we can say it is hyperadrenocorticism. Here also see this is the uh, cranial pole of the adrenal and this is the caudal pole of the adrenal. So caudal pole is very much enlarged. It is the adrenal tumor. Here also the cranial is normal and the caudal is enlarged. So again a tumor of the adrenal and this is again an adrenal tumor. So friends, these were all some of the commonly encountered pathological conditions of the organ of the abdominal system. And with this, we conclude this 3 days webinar series. I hope it could have been beneficial to you all, something you would must have retained. Now, for any questions, I hope maybe I have just covered all those questions also, which were asked in the group. I don't think any is left. If there is still some doubts associated, then please ask.
Ma'am, can you expect the hands-on training in this course?
Hello, sorry, your voice is breaking. I cannot get you.
I'm saying, can we expect a hands-on training program in coming days?
So you are not at all audible. You are not at all audible. Maybe some network issues.
Ma'am, he is asking about hands-on training.
I can't say anything about hands-on training for right now. I could just this see online webinar was something which is in my hand, but for providing hands-on, I don't know how it can be put into reality. Maybe you guys you just give some suggestions on your own, then we can think how it can be practical.
Ma'am, can we expect a similar course on radiography as well?
Sorry.
Ma'am, can we expect a similar course on radiography? Like in the
Yeah,
potential?
maybe in the near future. Sure, I can prepare. If all of you, maybe if some of you are showing interest, I can definitely give a presentation on radiography.
Thank you.
Okay. Any other doubts?
No, ma'am. I think we can close the session.
Okay. Thank you everyone for joining this session and making it a wonderful one. I hope it was useful in some aspect or the other. Thank you everyone.
Thank you, ma'am.
Thank you, ma'am.